Good evening and welcome to tonight's presentation from Orthobiogen here in Oklahoma City, where we're going to be having a webinar to discuss sciatica. And we're going to be going over that and sciatic pain and really help you understand more about what's going on. So my name is Dr. Keley Booth, and I am a spine and interventional joint specialist and here in Oklahoma City. And one of my favorite topics is sciatica. And as a spine and joint medicine specialist, this is one of the most common conditions experienced by patients that I have the pleasure of seeing on a daily basis. So almost not a day goes by that I don't have patients come in with this particular symptom. So, and in addition to understanding more about sciatica symptoms, I will go over some of the causes of this debilitating condition and help you understand more about it. So if you think of any questions, please send them in to the moderator, and I'll try to get those worked in and answered during the talk. So let's go ahead and get started. So, all right. So as we mentioned, we're basically talking about sciatica, sciatic nerve pain, and I'll give you a little bit of background on myself and Regenexx here before we get deep into that. So why am I qualified to talk about sciatica and kind of give you the information that you need to help you understand about this? I've been a physician now for, over 20 years, 21 years to be exact now. And I am an interventional spine and joint specialist and a board certified anesthesiologist. So I have focused my entire career on helping patients in pain and helping them really find ways to avoid surgery. And so that's a key motivator for me every day, always trying to help patients. And we can't always do that, but we do very often have opportunities to help patients. So, and why are you here? Well, hopefully you're here because you're experiencing symptoms or you're looking for information to try to understand this condition that maybe you were diagnosed with and you failed other treatments, or you're simply wanting to try to find an alternative. Maybe someone told you were a surgical candidate and you really want to try to avoid surgery. So seeking advanced treatment options, I think is smart in trying to find out, because, you know, many of the things that we do for our patients here are not routinely taught in traditional medical environments. You really have to go out and spend, you know, years, even decades to understand how to apply these types of treatments and therapies. So, and ultimately, you know, it's what we all want: less pain and more out of life. And so we want to be able to help you get that and achieve that. So, so basically, obstacles that get in the way: money, time, confusion, fear. You know, these probably sound quite familiar. And then who to trust about your information, about where you're getting this in terms of, you know, who has the knowledge base really to help me. And understand that if you come to this and you're working with patients, you know, and you come from, let's say, a surgeon's perspective, and you're only uniquely looking at it from that viewpoint, you come to this discussion about what to do, how to handle things, with a bias that you may not even realize. And I tell patients all the time, look, I have a bias too. And my bias is towards helping you get the lowest risk procedure that gives you the most likely benefit in terms of, or the most helpful outcome that we can to try to decrease pain. And so fortunately, I think, you know, that is a good way. You know, I think of my bias, I'd rather have my bias, you know, towards a non-surgical approach initially. Sometimes it's just not possible to avoid it entirely, but very often we are able to help patients, you know, do something else besides the most invasive thing available. All right, so why Regenexx? You know, in terms of a history, we're basically looking at this from the standpoint of, you know, Regenexx is the first group to really perform, and the physicians that founded Regenexx are the first to perform cell-based therapies, regenerative therapies in the spine in North America. So quite a history there dating back into the early 2000s in terms of applying this really novel and modern method. So relative to other things, you know, Regenexx currently has the largest registry by any regenerative care network of physicians, that's available in the U.S. So we've performed over 150,000 procedures as Regenexx physicians in total. And so we are really the most experienced network as a group of physicians really in the country in terms of providing treatments, not just to the spine, but also into peripheral joints and leveraging, treatments like PRP, cell-based therapies using bone marrow. And in addition, we have an impeccable safety record, really have tracked patients in some cases for well over a decade in our patient registry that shows that we do have quite a strong safety profile, especially compared to anything surgical. Outcomes are quite good. And so, and really a lot of that also comes from the standards that we hold ourselves to within the network and working towards essentially making sure that we do the absolute best for our patients. And we're always evolving, to the highest standard in terms of what the data supports and how to provide the highest level of safety. In addition, Regenexx has published a large proportion of the research that's even out there in this area. We have Regenexx physicians that are in the network who have had the great fortune to work with and learn from, who have actually published really landmark studies and even written medical textbooks that are used to train other physicians how to even perform these procedures. So that's pretty exciting. We have, I feel very lucky to be part of a network and grateful to be able to work with the caliber of physicians that I am able to call myself a friend, colleague, and coworkers with. So, all right. So we're going to, and that really got into a little bit of why Regenexx, America's most trusted really, for years. And here, we're about to celebrate our 18th year as a physician network in the United States, which is really outstanding. And of course the procedure numbers are always going up. So even since I've updated this information, we're now over 150,000. We have over 600 employers nationwide that actually provide Regenexx as a benefit for their employees. And that ends up covering hundreds of thousands of lives. And so patients are able to get that in some cases through the treatment covered through their employer-based insurance plans, which is pretty exciting. And one of the other critical things is we don't use foreign tissue, no foreign sourced amniotic birth tissues. We use your own tissue, which we believe gives you a better potential for healing based on the data that we have, and also reduces risk. So, all right. So in terms of our goals, then, we're going to help you identify whether you may be suffering from sciatica, help you learn more about the root causes of sciatica symptoms, and help you discover if you may be a candidate for Regenexx, which ultimately, that's going to be something that is determined by either myself or another Regenexx physician in consultation with a complete evaluation that would be necessary to determine that. But you'll get, I think, a strong idea from our talk tonight that will give you some understanding of whether or not you may be a candidate. All right, so we're going to jump in here. All right, so sciatica, what does that mean in terms of a definition? And I took this straight from the medical dictionary that you can access online, directly. I think this is the Merriam-Webster version. And it talks about, pain along the course of the sciatic nerve, which I'll show you shortly, because many people say, well, I'm not quite sure where that sciatic nerve is. And essentially goes down the back of the thigh and typically involves both back pain as well as buttock pain and into the hips or down the leg. And some people will experience pain all the way down into the foot. Okay. And so, all right. And then sciatic nerve distribution, if you will, where does this nerve go? What sensation does it provide? This gives you an indication here in red, as you can see, down the leg here. So, and you can see essentially the course of that nerve down the leg. And here, we'll get into more of this later, but these are some of the things that can cause that problem. If that nerve gets pinched, right, a so-called pinched nerve in the back that many of us have heard about, what does that mean? Well, after today's talk, you're going to know a lot more about what that means and where that comes from. All right. So again, common causes: bulging, protruding, or herniated lumbar discs. We'll talk about a little bit about the differences there. And if you've had an MRI ever, you've probably seen bulging, protrusion, or herniated discs. A lot of times these findings are used to justify surgery, despite the fact that more people have these findings than have symptoms from those findings. So it is rather uncommon to have a normal MRI beyond a certain age. It's one of these things where, if I just randomly grabbed a 50-year-old person from the parking lot, the odds are very high, extremely high, that if I took an MRI of their low back, they would actually have at least some bulging and potentially even protrusion of discs, but they may not even be aware of that, and they may have had that for years. So that in and of itself, I want to caution everyone that's listening to don't assume that you need surgery on the basis of finding something on your MRI. So if it says something other than normal, that in itself beyond a certain age is normal. And I tell patients, if you can come in here and show me a perfectly normal spine, in a middle-aged person, that's rather rare. I may go, most of the year and not see that, because sometimes people get, coincidentally, they'll have an MRI for something else, or they're trying to rule something out, and they say, oh, by the way, you had some bulging discs, and then they get worried about it. Really don't need to worry all that much about that. So, all right. So degenerative disc disease. This is something that, again, very age related. Maybe you have a job that involves, so my ranchers, my farmers, my truck drivers, those patients very often are not going to probably escape, long-term career in those fields without some level of degenerative disc disease. Very common, but don't necessitate surgery in most instances. In the overwhelming majority of cases, surgery is not necessarily needed. And the overwhelming majority of the time when surgery is performed, it is an elective procedure, not something that you have to have done. So, all right. So then we'll talk also a little bit about lumbar spondylosis, which is essentially this combination of facet joints and disease and arthritis. So it's most commonly linked to, if you were going to hear someone talk about that, it's when they say, hey, you've got some arthritis in your back. And I'll show you those joints tonight so that you can kind of understand where that's at and a little bit about maybe even what the symptoms may be. While those aren't specifically necessarily sciatica, they can be linked to some of the pain that you suffer with sciatica. So, and lumbar spinal canal stenosis, another one I'll show you, which is essentially some tightening within the canal where your spinal cord travels. And then we've also got sacroiliac joint pain or hip conditions that can actually mimic or seem very similar to sciatica. So you can see this with this list alone, really sciatica doesn't narrow things down to a very specific cause. If anything, it just gives you a general idea of the symptoms that a patient is experiencing. So if I'm going to provide treatment and help a patient that has symptoms of sciatica, it is critical that we dig deeper into the problem before we ever go and entertain, performing a treatment. So, all right. So, and then jumping into it here, we're going to talk about disc bulges, protrusions, and herniations. So this is actually a case where I was working with a patient, middle-aged patient in their 40s that had come to me with just back pain, technically not sciatica. Okay. So I think that's a big distinction here is that sciatica typically means you're having both back pain and leg pain, or at least into the buttock region, maybe into the thigh. So That's the classical symptom there. So, but here you can see, and I've highlighted this disc that actually has damage here. And I want to use this disc here, which we would call an L4-5 disc, which is in kind of an in between the bones, if you will. You can see this little black area that's kind of bulging out the back. And then on this image, you can actually see where that bulge is actually coming out into the canal. And these little gray dots in here are the actual nerve roots. And we talk about pinching of nerves, and you'll see here in just a minute how someone could go from back pain with a disc that's having a problem. And this patient literally came to me with that. And then 2 months later came to me with a new pain that he had not experienced before, or at least not frequently, and said, hey, doc, you know, I was doing this activity and then something changed and now I have leg pain. And that's what this image down here is. And you can literally see the change here. And there's even a difference in how this disc, and that's the red portion here that you see I've highlighted for you. This is the nerve root. And you can see here where the disc actually literally bulged out and now is in direct contact with that nerve. And that nerve has to transition through this area to get out to the leg. And so it's no wonder that he's having leg pain now. The other big difference you can see, and this is pretty dramatic, now just to show you how these things can change over time, you see the bulge here. This is the same disc. And now you can see where this is fully herniated. And this is a very good example of a disc going from a bulge and a protrusion out to a frankly herniated disc. So a portion of the disc has come out almost like toothpaste out into the canal. So you can actually see that that is now pushing. And again, you can see the close approximation. These little gray lines here are the actual nerve roots. And you can see how now those nerve roots don't have as much room to pass by through this spinal canal. So, so this is really showing you the evolution from bulging to protrusion, herniation, and even into nerve impingement. And so I don't want to get too into the medical jargon, but all of this develops into something called neuroforaminal stenosis, also when you have a bulge out here. So if you've seen that term before on your MRI, that is, this is related to that also. So, but that obviously can cause, you know, nerve pinching, and you can see why we call it impingement. All right. So now I'm going to bounce over to our tool here and talk about the sciatic nerve. I promised you I would kind of help you understand. Now, this is our 3D guy here that helps us explain things to patients when they come in and we're trying to show things. So bear with me here. We'll kind of zoom in, and I've turned him around. So now I'm going to click in to his backside here, and it's going to zoom in. And then basically what I'm going to show you is this area here, what I've highlighted in purple, and you can actually see right along here, this is the sciatic nerve. And so I'm going to kind of come down here, and you can see how that can come down the leg, and I'm going to rotate around. Now this is the hip area. And so just to get us some sense of where we're at, I'm going to throw on some skin here so you can see the backside of the patient there. So sorry, didn't mean to give everybody a good view of the rear end, but that's kind of the anatomy. That's the way it goes. So, all right. So, but basically this nerve travels down that leg, and you can see as I highlight it here, it then starts splitting into several different areas. And so these nerves are all along the course of the leg, and this can travel all the way down. So now we're down into even the knee. And so these travel along. When you have sciatica, you typically have a dermatomal pattern or distribution, we would call it. And that is something that I can show you. I'm going to zoom out here so that you can see the lines associated with individual nerves and the pattern that takes. So this is our really colorful line there, so that if someone had an L4 nerve root compression, not unlike the patient that I showed the MRI of earlier, he was having pain in this distribution down the leg, and very often it would wrap around the leg and actually come and all the way to here. You can see that. So you can see how that wraps around, and we can get a sense of what nerves are being impacted based on, are you having pain on the outside of the foot, top of the foot, bottom of the foot? And so here, see, I can rotate that up and show you. And that's right where that would come down. And depending on which nerve is compressed, that's what generates your symptoms. So that helps you kind of understand that. So that is a sciatic nerve in a nutshell. So hopefully that helps kind of understand a little bit about why you may be feeling that. All right. So now we're going to stop and answer a couple questions that we have coming in order to clarify things. I know I went over a lot there and kind of sometimes going a little fast, but many of you may have questions relating to yourselves as individuals. So we're going to get a couple of questions in here. And so in terms of, let's see here, I'm checking out my questions. So let's see, can this help me if I have scoliosis? All right, so that's a good question. So having scoliosis does not necessarily mean that you are going to have sciatica. And it's important to understand that there's many different kinds of scoliosis. And that is actually a common feature as we age. People will tend to get curvature of their spine. You may have seen, for example, chiropractors very often will go out and take images of backs and see those curvatures and explain that, you know, some of your symptoms may be coming from that. So, you know, scoliosis doesn't necessarily cause sciatica, but there are, you know, it's a common coexisting theme that you could have sciatica with some level of scoliosis, but technically very different conditions. And so I think there was another question that we had in there as well. And let's see, how do you know that you have sciatica? All right. And it's really as simple as this. If you have chronic recurrent pain into the back and down the buttocks or into the back of the leg, you know, and even down all the way to the foot. And if that's something that, even if it comes and goes or it stays consistently, maybe different reasons why it's doing that, but then technically you have sciatica. So there's really not a lot of, it's kind of a clinical diagnosis. Do you have those generalized symptoms? And that is something, you know, literally right now in the United States, there's tens of millions of people suffering from sciatica, you know, at some point in the day, the week, or the month. And but it's not a group of symptoms that necessarily leads you always to surgery, and that's very important to know. And I think a lot of people don't realize that, and they just assume, well, I hear I've got sciatica, I have to have surgery, and that's just not the case. And actually, the overwhelming majority of the literature that's looked at these things says that that is a lot of people can get better without surgery. Okay, all right. So now moving on to spinal canal stenosis. Okay, so this is less about the disc bulges themselves. However, the bulging of the discs can affect this. So and this is another finding that you'll see very often. Again, if you've had an MRI, you read a report and you're trying to figure out what's going on. So here I've actually taken one of our patients that has a history of spinal stenosis, and you can see here the little red highlighted area. And you know, we often say, boy, this looks almost like hot links here, or it's got kind of this constriction and hourglass shape at the multiple levels, and you can see how that comes in. And if you recall the other images that we were looking at, they didn't really have that. They weren't suffering from spinal canal stenosis, but this is kind of a classic case of that. And so this is that side view of the spine. And here you can see this little red sliver of space. That's quite small. And I'm going to jump back a couple slides, and I want you to look at this area, okay, and compare that to this area, okay? That's the same region of the spine, and you can see how wide open and white spaces, and you've got the nerves there. Well, imagine if that was cut all the way down to this area. Boy, that's tough. That means all of those nerve roots that's got to travel through that area of the spine are now jammed together. And what happens is when you bend, you move, or you twist, those nerves are getting pinched and stretched. And that can give you symptoms of sciatica. So, so that is a something that can give you essentially some symptoms that would be very familiar to those of us in our specialty, and can cause a lot of problems. So you can see how wide and varied the things that cause the problems are. And so this lack of space, right, which I'm going to jump in here and show you. So we're back to our anatomy, and I'm going to zoom into the specific bone, okay, that we were looking at, the specific level, I should say, that we were looking at here. Sorry, I'm trying to zoom. Let's see if it'll let me. There we go. And I'm going to kind of center this up. And now what I'm going to do is I'm going to isolate this bone to really show you, and watch closely here, because as I isolate this bone is going to flip up, and we're going to actually be able to rotate it around. So now as I rotate that, and we're looking down the spinal canal, you can see this kind of triangular shape. This is the actual canal. And you can see in the picture that we were looking at, boy, that space was nowhere near this size. And that's really what canal stenosis is. And so that's something that's a unique problem, and very often gives you even symptoms on both sides. And you may actually have sciatica going down both legs if you're suffering from that. So that's one of the hints that we need to kind of look for that. All right. So, so that gives you some insight into that area. I'm going to go back and all right. So now we're going to talk about multifidi muscles. And this is an area where not necessarily causing sciatica directly, but over a period of time with laxity, weakness in the back, you certainly can be more likely. And there's many studies published of linking weakness in these muscles that exist within the spine, to back pain and back problems. And very often I see this coexisting with sciatica or sciatic nerve pain in patients. So, and these are two very different patients. I wanted to give a sense of, the difference that can occur here. And right here, I'm kind of highlighting this dark area. This is actually the rector spinae and multifidi muscles here. And these are extremely well developed in a former athlete. So this patient had lifted a lot of weights in their lifetime, and actually really has some pretty exquisite musculature here when you see that rounded shape. So now I want you to compare and contrast that with this patient's, where you actually see white here, and you see virtually all of it is white. Well, the problem with that is that means that all the muscle has gotten essentially replaced by atrophy. And so that is basically giving you an idea of what happens when you got damage to the muscles, okay? So when we've got that happening, very often, this is what I see post-surgery, okay? This is actually really common. When I don't see some level of significant atrophy post-surgery, I'm pretty surprised, because it almost always happens to some degree. And you can see that there is essentially no active muscle here. So what do you think happens to, these levels below the area where you no longer have these stabilizing muscles? Well, they become, weak, and then you end up having instability, and very often that level degenerates as well. So not something we like to see at all. And so, all right, so I'm going to go over here, and we're going to take a quick look at, let me go back, and we're going to slide over. And I did want you to be able to see these muscles and kind of show how that works. And so I've got to layer in my muscles here. So check this out here. And then you can see here, as I'm layering these in, I've got these muscles running up and down the spine, okay? And so as I do that, we're basically pointing out the muscles that we were seeing in cross section. And you can see there's quite a lot of muscles, and see how those just layer on and layer on. But right in here, I'm going to zoom in. Let's see. And then we can actually, and now this is the longissimus muscle that's actually showing here. And so what I can do is hide that one, and then we can go in a little deeper. And so there's those multifidi muscles that I really wanted you to see. And I'm going to hide here and kind of get you an idea of what these muscles can do. And let's see if I can get it to lock on for both muscles. There we go. And then we can actually do something here where we can actually explode that, and you can really see, boy, look at those muscles and how far they travel up the spine, and they're critical. And so these are the muscles that you really want working, and we really want to work on physical therapy and specific types of exercises to maintain these over your lifetime. So, all right. So that gives you an idea of those muscles. We're going to move on here. And all right. So we're going to jump into some questions. And so we're going to identify if we've got a couple questions here from our team. Sport team's got some things going here. All right. So is there anything I can do to help my back pain? I'm assuming in relative to the muscles and the multifidi muscles. So yes, as we mentioned, you want to maintain muscles and general health and frankly, an active lifestyle, which we all kind of know that we can essentially work on the muscles through our diet, nutrition. You want to support that with protein so that you can have that nice, essentially, you don't want your back muscles. If it were steak, right? You went to the supermarket and you found that, hey, this steak has extra fat on it versus this one is pretty lean. We want our muscle to be very lean, and that will allow it to be stronger. And we have studies that show that the actual size of those muscles actually can predict who's more likely to have back pain and develop sciatica and other types of back conditions, just based on analyzing the area or the volume, if you will, of that muscle group. And so that's something. And that's one thing too that's unique to know, that, in traditional medicine, about the only thing we do with those muscles is cut through them in surgery, right? And which causes damage and weakens the areas above and below. Or we go in and we do what's called trigger point injections in traditional medicine. And that essentially just turns the muscle off for a little while, causes it to be relaxed, and then it wakes back up, several hours later. And those are typically short-lived benefits that you would get. And they certainly don't necessarily work for long-term to aid you in having a stronger muscle group that's going to support you throughout your lifetime. And there's some concern when we look at doing radiofrequency ablation. Is there an impact? And there's some concern that can weaken certain areas of those multifidi muscles. So you want to think about that too, if you're looking at more of a regenerative approach versus doing just treating pain. The regenerative approach is going to be, hey, let's recruit those muscles. And with Regenexx, we actually put biological material in there to basically help your muscle get stronger and develop. And all of our patients will be in therapy post-treatment from our spine treatments. And the multifidi is a big reason why we want to help that muscle out. So, all right. So some of the less common causes of sciatica, misalignment of spinal bones, or spondylolisthesis, which is a word that you may see sometimes on MRIs. Not one that gets thrown around the office a whole lot, kind of difficult to say, and kind of confuses people because there's spondylolysis, spondylolisthesis, there's lumbar spondylosis, and all of those things kind of get mixed together unless you deal with this every day, all the time, and are working with spine patients. So even your primary care doctor may not quite keep these straight, but I'm gonna take the mystery out of it here in a minute and show you kind of what is spondylolisthesis and the misalignment of these lumbar spine bones, and how does it relate to sciatica, and why would it cause a problem. The other things that less common than some of the other things that we see, but still pretty common, deep gluteal syndromes such as piriformis syndrome. There's a whole constellation of muscles that are in and around that sciatic nerve that can actually cause a problem. And I'll show those to you here in just a minute so you can understand the complexity of the muscles. And if those are spasming or encroaching in and around that sciatic nerve, you're going to potentially have some pain. And those are the tough ones because sometimes that's intermittent. You may not always catch it. You may move wrong. You're doing some activity and it fires it up. For our weekend warriors, the people that are out there, you did a new activity and you're not sure what's going on, but usually responds well to lower levels of treatment, very straightforward things like PT. All right, so rare causes, malignancy, hematoma, and abscess. I have to mention these, although quite rare. We always have to keep those in mind when we're evaluating patients. And some patients say, I don't understand why I have to go through all these evaluations and get, imaging when I know what's wrong. And, I had the same thing 5 years ago. Well, it could be a new thing. And you never want to miss something like this because it can be, in rare cases, it can be life-threatening or can threaten harm to your nervous system that could be irreparable. So you really want to monitor for these things. And we're always looking for these things to try to make sure that we're not seeing anything that would cause a big problem that need to be addressed right away. So, all right. So spondylolisthesis, I promised you I'd explain that. So basically the bones are sliding forward. And so I'll kind of show you that basically if these were two bones, they would slide forward on one another. Okay. And so the grading of this condition is based on how much slippage between the bones there are. So you can see here, less than 25% of this area across the bone would be a grade 1. These grade 1 and grade 2 are by far and away the most common. It's rather rare to see a grade 3 or 4 because by the time you can see this would be quite a problem for you. At a grade 3 or grade 4, your spinal cord or your nerves have to weave their way through that canal that I showed you earlier. And think of it like Swiss cheese, and we're trying to get these holes lined up. So if we've got these holes and they're lining up and we're kind of going in and out like that, boy, that's a problem because that nerve has to course its way through all of these areas. And that means it has a greater distance, and it essentially puts tension on the nerves. And this can actually threaten the nerve's function and could cause permanent damage and even motor weakness, loss of, so can actually, create some big problems here. So, all right, sorry, I jumped forward there. So deep gluteal syndrome, this is this constellation of symptoms. We used to talk a lot about piriformis syndrome, but there's a lot of other things that can impinge in and around the sciatic nerve beyond just the piriformis. Probably one of the most common things I hear back from therapists, from our physical therapy colleagues, is piriformis syndrome. And that is something, but it is possible that there are several other things and muscles in the area that can cause problems. And so, so real briefly here, I'm going to show you these gluteal muscles. So we're going to come up here. We were looking at the multifidi muscles, and now we're going to jump down here and layer back in here. I'm going to show all the hidden muscles. And here we've got the gluteus maximus, which everybody knows that one, your backside muscle there. And then we're going to hide this muscle so that we can look under it. And so if you're having issues with these muscles in here, you can actually see where this nerve is. So where that just highlighted here, I'm going to undo that. And so, and let's see this, I'm going to hide the gluteus maximus muscle again here. And so my keyboard's not liking me. So right here, you can see that nerve. So you can imagine if this muscle is pinching, and I don't want to do that. So here, I'm going to click off my hide. So let's exit that. All right. So here, I'm going to hide that one more time. And then, but right here, these muscles in this whole area, there's a large group of muscles that you can essentially cause problems, right, with this nerve. And you can see how it's really what we would call invested in that area. And so the idea here is basically to, let's do this. Let's fade the others and fade that. And you can actually see how that looks. And so we're looking at from the side and from the back, and you can see how those muscles really could squeeze down on that nerve. So helpful to understand that there's a complex group of muscles back there that can actually lead to that and can actually cause all of the symptoms of sciatica, which again, you're starting to get the understanding that sciatica is a lot more complex than people realize. All right, so regenerative approaches to how we address this, right? So we get in there and we actually look at doing intralaminar, transforaminal, epidural. So there's multiple types of epidurals. Sometimes even we'll perform even a caudal approach. So we have multiple ways in and around the nerves to help put regenerative medicine in there to try to decrease inflammation and help those nerves function better. We also treat in and around the facets. I promised I would show you those, so that's coming up in just a second. And then lumbar ligament injections, which is something unique typically to regenerative physicians. And we work on those ligaments to help keep those bones together. That's what links those bones and gives you that passive stabilization, so that even if the muscles were completely asleep and not doing anything, your spine would stay together because of the structural strength provided by the ligaments. And then, of course, the multifidus. We went into detail there. We do treat in and around the multifidi muscles to try to help support the back. And then combination physical therapy with our treatments is an important part of what we do. And we marry those two things together routinely to benefit patients. All right. So right here, I'm going to go ahead and go back to the home base on our guy here. And you can see here, he's got lots of muscle layers enabled, and I'm going to just peel those back one at a time. And then we're going to zoom right in to the low back. So now we're back in that region where, and this is kind of to show you what we would do in order to treat. Okay. So, and if I was coming in to treat this patient, and let's say, we were looking at the L4 and L5 and S1, which is down here. So this is S1, L5, and L4. So if I wanted to treat this patient's facet joints where they're having, we mentioned the term lumbar spondylosis or arthritis of the back, we would literally come in here just like this. And we use a specialized X-ray machine that shows me a view, not unlike what we're looking at here. And we actually inject into the joint. And this has a joint capsule on it. And I'll show you what that looks like. So here in just a second, there you go. And so there is the joint capsule, and you can see it highlighted all the joint capsules of these lumbar facet joints. And so we'll treat in and around those. We'll also do something called transforaminal epidurals, and we'll get a view about like this, and we'll actually go in and put medicine down deep in here. And so you can see where this nerve right here, there's little nerve roots down in here. And so I'm going to zoom in and show you what that looks like. So right around in here, you can actually see where the disc would be. So the disc would be right here, and I'm going to layer that disc in so that you can see that. And I'm going to disable this particular tissue. So let's hide that for now. But right here, this particular disc is in close proximity. And you can see that little white tissue pushing, but it can push on the disc and the nerve root. So we actually go in here and treat that. And then that the tissue that I hid there that is in green. So now you can actually see what's called the intertransverse ligaments, and those connect the bones here, providing stabilization. And Regenexx, we also treat those. And so we'll actually get in there, and then as well as some of the sacroiliac ligaments. And there's another large important ligament down here called the iliolumbar ligament. And you can actually see how these things are all connected. And so we're basically going to treat all of that. So we'll go into detail at the time of your visit, but you get the idea that there's quite a lot going on here in terms of your anatomy that can affect that. And that kind of gives you the idea of regenerative. So real briefly, we'll go over a couple of, just to wrap up, traditional surgical approaches. What's the evidence behind that? What does the latest research say? And I have to point this out because this is a common refrain that we get, is that, well, research behind regenerative, research behind these things. But, currently, and this is important to know, this is a study that was done and published in 2021. Okay. So just within the last couple of years. And their assessment, these experts said no randomized controlled trials have compared lumbar spinal decompression with no treatment or placebo, meaning, essentially doing fake surgery is what that would mean, is make an incision and compare it. So we don't really have a comparison of how would patients do if you just didn't treat them at all, or you gave them conservative treatment. And the single selected randomized controlled trial that represented the best evidence compared the decompression with conservative treatment, which was minimal conservative treatment. They're not talking about regenerative here. They're talking about comparing it to steroids and physical therapy. And both treatment groups showed improvement during follow-up with no difference in their walking ability. So they weren't able to discern really who did better versus surgery and who did better on the other side with doing so-called conservative treatments, which involved steroids and therapy. I would put that in there that, boy, I'd love to go head to head with that patient population with a regenerative treatment that's a much more natural approach, and you wouldn't have the side effects and the potential downsides of the steroids. All right. So why do surgeons continue to perform unnecessary surgery? This was actually published in 2017. And, multiple clinical trials have shown spine fusions for back pain, like sciatica, do not lead to improved long-term patient outcomes when compared to non-operative treatment modalities. And again, they're comparing that not to regenerative treatment, but they're comparing that to basic things that are out there. So it's important for you to keep that in mind. And this goes to show my point that it doesn't, just having sciatica does not mean that you need surgery. And typically, patients are well served to slow down, take some time to find out what their options are. Okay. All right. So we're on the last bit of questions here, and we're going to go here into just kind of wrapping things up. And at this point, we had a couple questions, I think. So let's see, another one came in, and let's see which number. All right. So how long would it take to recover from treatment for regenerative treatment? That's one of the best things about it. Recovery from regenerative, our patients are typically getting back to normal activities in a matter of days or a week. And they're able to, for us, a typical recovery period post-procedure, right? We're getting patients back to their baseline pain levels, typically in about a week or so. And sometimes sooner, depending on what we treat. More extensive treatment, maybe a little more than a week, but then beyond that, we're looking at, these things where we're looking at that and saying, hey, because of the minimally invasive nature of what it is we do, we're able to really get recovery times down, measured in much lower times. And we have the ability to prove over time, and dramatically so. So one of the things that I didn't show, but I can cross over here briefly and let you show. This is actually the lumbar spine outcomes that are currently available. If you want to go and look these up, and you can actually pull this up on the Regenexx website. And this talks about the outcomes of over 11,000 patients that are tracked in this database. And so here you can actually see over time, the time of the procedure and compared 1 month, 3 months, 6 months, and you can see how this trend goes higher over time, which is great because we don't see that typically with traditional non-surgical approaches such as steroid-based therapy. And that's what's so exciting about providing this treatment to patients, is that we typically see a much longer window. And these are not multiple treatments. The overwhelming majority of these patients had a single treatment as they're going along here. So that's great news, and should be encouragement for you to consider, looking into this. And as a treatment option for you if you are suffering from sciatica. All right, so what we're going to do here is go back over. All right, and so basically, let's see, I did have a comment that came in. Well, thank you. I got a shout out from Matthew, and thanking us for what we do, and I certainly appreciate that. Thanks, Matt. And that's nice to hear that we're he's telling us that they appreciate it. So one of the other questions we had is, let's see here, coming in from Denise. So lumbar 1 through 5, only option I've been given is surgery, rods, fusion. And I have all you've been discussing. So spondylitis, stenosis, and 6-month recovery for surgery. At 65 years old, a lot of pain, would I be a candidate? I would say definitely you would want to have an evaluation. Anytime we hear a story like that, and we're talking about a 5-level, it sounds like fusion, that could be life-changing for you. And you really want to open up your mind to the possibility of, hey, maybe there's another way. And I'll tell you this, I'll tell you a quick story about my brother-in-law that actually was suffering back pain. And he was a high school athlete and had done many things in his life, wrestled, football, and a lifelong weightlifter, and was suffering from back pain. And he came to me and said, hey, do you think that you could help me with this? Because they're telling me I have to go get, a 2-level spine fusion. And I said, wow, that's a big deal. Let's come in, let's talk, and let's go over things. And, we went over that, did the imaging, did all the analysis. And I said, yeah, you're a candidate for this. And he was having severe leg pain. He couldn't get on an airplane without having pain go down his leg and cause numbness. And he couldn't hardly get out of the plane, off the plane, because of the seat would cause so much trouble for him. So ultimately what we did, just kind of summarizing, we did a Regenexx treatment for him, and he was able to do so well that he had just a slight residual and not continuous, but a recurrent occasional pain that he was having there because he had a mechanical problem. So what was so exciting is that we took him from a situation where he was told he had to have a multi-level fusion, and he ultimately had something called a microdiscectomy through a 1-inch incision, and he left the hospital that same day. So I use that as an example of where, that's a situation where it modified the trajectory of his surgical care based on what we were able to achieve, because at first he was, going to go for a multi-level fusion, and that would have changed really his workouts and everything significantly. So I encourage you to schedule an evaluation. That's really the only way to know for sure, but I think that there is potential here. So, all right. So I also had another quick question. I'll try to jump on this. So please compare the surgical procedure versus a regenerative procedure for sciatic nerve pain. And so, that's probably a longer question, but I'll hit the highlights. Okay. So interested to hear the outcomes, recovery times, and dangers. All right. So when we compare regenerative to surgical, I tell patients, look, this is another realm of risk in terms of surgical. And I can say that having personally been involved as a board certified anesthesiologist for years and years, and run entire surgical departments. I have been in the OR and have been there when there's complications, with spine surgery. I will tell you that it's an entirely different risk level, one, because of how relatively invasive a spine surgery would be. Now, again, I'm taking spine surgery in general, and I'm assuming there's fusions in there and potentially multi-level treatments. There are certainly a lot of safely performed spine surgeries done every day in the United States. However, when you're using a scalpel and you're going through tissue versus using a very small needle, and I explain to patients, when I perform a spine procedure, very often the largest needle that I'm actually going to use for you is the IV needle that we use to sedate you. So imagine that. So I am causing such a small footprint in such a small area that the risk profile of that versus surgery is quite different. And so, when you talk bleeding, infection risk, all of those things are dramatically lower for a regenerative spine procedure versus a spine surgery. And that's just, the benefit that we get by having a much smaller footprint in there. Now, in terms of outcomes, that's difficult to say because, again, what's the diagnosis, what level of severity? And there are patients that come in and, If you've got severe motor weakness and you're not able to move your legs, that's another level, right? But that's not the typical patient. Most people that I see that have surgery do not have those kinds of symptoms. So, so when we talk outcomes, are we going to be able to take away all the motor weakness if that's what you're experiencing? We have to really, be conservative and estimate on the lower side. So, but when it comes to pain, we actually have very good outcomes. And so I would expect, higher recoveries. And I point you back to, and I'm going to show this real briefly here again, because I think this really, answers that question better than I could in just a matter of a few minutes. But come take a look on Regenexx.com under the results section and look at the reported data that we use in our patient registry. These are patients that have been treated using our protocols, the same protocols that we use here in our practice. And you can see the changes over time. And again, this is data that is over 11,000 patients tracked over years. And so I would kind of point to that as far as outcomes go. But again, you'd have to take into consideration what is the diagnosis of the patient, what pathology you have. And you also need to understand that some patients simply are not good candidates for the procedure, and we don't recommend it because things are maybe a little far out from what we would typically address. So hopefully that gives you some insight, and I answered that question reasonably well. Okay. And one last question. All right. So transitioning this information into neck pain, numbness, hands, feet, having been diagnosed with canal stenosis, facet arthrosis, neuroforaminal stenosis, are you a candidate for treatment? So in this scenario, neck problems, a lot of what we talk about in the lumbar spine transitions, because all of those things that we talk about in those areas that you can have discs pushing and bulging, those can all potentially benefit. There are some unique concerns because there's some sensitive real estate in that cervical region, and we have to take that into account. But we do provide treatment to the cervical spine, the cervical facet joints, epidurals, and also treatments into the ligamentous tissue. And we're going to be doing one in the future, another talk specifically about cervical spine and what the advantages are. But again, this gets down to what is ultimately the diagnosis. And that's what we find is lacking a lot of times is we spend a tremendous amount of time working with patients, working them up, trying to help essentially understand that, the diagnosis is key. And very often there's more than one thing. Very often there's more than 2 or 3 things. And we've got to really pull all of those together and treat this spine as a functional unit, not just, hey, you've got this one thing and we're looking for that one-hit wonder. We're not. We're actually trying to make your spine function as well as it can and function together as a unit so that you can do better. So, all right. So we're going to go ahead and get ready to wind things down. And boy, great questions tonight. I really appreciate that. And that gives me an opportunity, to share with you guys some more on a personal level, right? What we may be able to do for you. And I just encourage you to, and even if you're not in Oklahoma City, we have, locations in Oklahoma City as well as in the Tulsa Metro, Broken Arrow. So for those of you that are in those geographic locations, if you're not, and you may be tuning in, we've had patients, pop in from around the country. Seek out your local Regenexx provider. And I can tell you that we all share the same passion for what it is we do. And I want you to know that if I were, and when I have my own musculoskeletal health problems, those are the people that I lean on personally for myself and my family members to help me get through those rough times and avoid surgery. And so far, we've been able to do that. But just keep in mind that you're probably not getting the whole story, because they'll say, look, there's nothing else available. Well, just because the doctor that you're with doesn't know about it doesn't mean there's not something else available. And I'd encourage you just to explore what else is out there and consider a treatment alternative, because, I tell patients, if a non-invasive regenerative procedure is not able to get you where you want to go, you can always have surgery. But it's extremely difficult, if not impossible, to go in reverse, right? And I never want to have a patient tell me, you know, boy, I wish you would have explained to me, you know, that it's a potentially life-changing thing, right, to have this done. And nobody wants it done, and some people really do need it. But you know, there's some concern that patients aren't being offered more opportunities to potentially avoid you know, invasive procedures that can, unfortunately, you know, change your life in negative ways. And so I look forward to the opportunity to meet you personally, to go over your case. We take our time, just like we've done in this presentation, to help patients understand what is going on with their specific situation and get a diagnosis. So what I'd like to do is invite you personally, you know, to our practice here at Orthobiogen in Oklahoma City. And we love what we do. I feel very lucky to have found my path, if you will, and with Regenexx and performing regenerative procedures. And we look forward to meeting you personally and helping you. So thanks again for tuning in. And until next time, stay healthy and stay active. All right.